Hello everyone. In this video, we will see about the complete median nerve anatomy starting from its formation, course, distribution and the applied aspects. We all know the brachial plexus arises from the ventral primary rami of C5, C6, C7, C8 and T1 roots. So these are the ventral primary rami. From that, C5 and C6 root combine to form the upper trunk. C7 alone continues as a middle trunk. C8 and T1 combine to form the lower trunk. All these trunks are divided into anterior and posterior branches, out of which anterior branch of upper and middle trunk joins to form the lateral cord. Then the anterior division of lower trunk continues as a medial cord. All the posterior division combine to form the posterior cord. Okay, this lateral, posterior and medial is in relation to the second part of axillary artery in the axilla. After that, median nerve arises from the two roots, that is lateral root and the medial root. Lateral root arises from the lateral cord, medial root arises from the medial cord, both joins to form the median nerve. If we see, this lateral cord arises from C5, C6 and C7. Okay, and this medial cord arises from C8 and T1. So this lateral root and medial root, when it joins to form the median nerve, which consists of fiber from all the root forming the brachial plexus, that is C5, C6, C7, C8 and T1. So when the median nerve is formed in the region of axilla, it lies lateral to the axillary artery. So there is no branches of the median nerve in the axilla. When it continues to the arm from the inferior part of the teres major, in the proximal part of the arm, it still lies lateral to the brachial artery. In the middle of the arm, at the level of insertion of coracobrachialis, the median nerve crosses the brachial artery in front and comes to the medial. Okay, from lateral to medial, median nerve crosses at the level of insertion of coracobrachialis. After that, it runs downwards and enters into the cubital fossa. In the cubital fossa, this is the medial most structure. Okay, so there is a separate video on cubital fossa with its contents and boundaries. So I will give in the description. So in the cubital fossa, median nerve lies in the medialmost part. Here it gives branches to the pronator teres and few other superficial muscles. Okay, in the cubital fossa. Then from this median nerve leaves the cubital fossa by passing through the two heads of pronator teres. So after passing through the two heads of pronator teres, this nerve, the median nerve, lies in between the superficial and deep layer of muscles. That is, it just lies below the or deep to the flexor digitorum superficialis. After it leaves the pronator teres muscle, it gives the branch, that is the deeper branch, that is known as anterior interosseous nerve. So anterior interosseous nerve continue, and here this is the median nerve continuation. This anterior interosseous nerve mainly supplies the deep muscles, that is two and a half muscle actually. There are three deep muscle: flexor pollicis longus, flexor digitorum profundus and pronator quadratus. It supplies completely the flexor pollicis longus and pronator quadratus, and lateral half of flexor digitorum profundus. Medial half is supplied by the ulnar nerve. Then it supplies median nerve superficial branch. It will supply all the superficial muscles of the forearm. At the level of mid forearm level, it gives the branch to flexor digitorum superficialis radial head. Okay, remaining all other head will receive the branch close to the cubital fossa itself. Only the radial head from which the tendon to the index finger will be coming, that will be given in the level of mid arm. Okay, this point is important when we are seeing the clinical aspects. When it proceeds distally, this will be lying deep to the flexor digitorum superficialis. 5 centimeter from the wrist joint. Okay, 5 centimeter proximal to the wrist joint. Median nerve comes bit superficially and located lateral to the flexor digitorum superficialis. Okay, so the medial nerve will be lying lateral to the flexor digitorum superficialis in the distal forearm. From there, there is a cutaneous branch which is known as the palmar cutaneous branch from the median nerve arises, and it will go superficial to the flexor retinaculum. The actual median nerve will enter into the carpal tunnel that is deep to the flexor retinaculum along with 9 other tendons. Okay, so 4 tendon of flexor digitorum superficialis, 4 tendon of flexor digitorum profundus, and the tendon of flexor pollicis longus. Okay, along with these 9 tendon, only one nervous structure, that is the median nerve, passes in the carpal tunnel. In the distal forearm relation of the median nerve, just laterally there is a flexor carpi radialis tendon. Okay, still lateral to the tendon, the radial artery will be there. So for easy remembering, you can keep the flexor carpi radialis, then lateral to that radial artery, medial to that median nerve. So in other way to remember in the easy manner, radially, that is lateral, other term, radially radial artery, medially median nerve. Okay, so flexor carpi radialis tendon is there, radially radial artery, medially median nerve. Median nerve flattens in the distal border of flexor retinaculum when it enters into the hand, and it divides into lateral division and the medial division. When the lateral division proceeds further, it gives the recurrent branch which revert back and supply to the thenar group of muscle that includes abductor pollicis brevis, apponens pollicis, and the superficial head of flexor pollicis brevis. Usually, this deep head of flexor pollicis brevis receive the additional branch from the ulnar nerve. After supplying to the thenar group, this lateral division proceeds further and it will be giving off the 3 palmar digital branches. Then from the medial division, after supplying the first and second lumbricals, okay, so first and second lumbricals, it proceeds further and it gives off the 2 palmar digital branches. So all these 5 palmar digital branches will supply the lateral 3 end of digits, including the nail bud and skin over the dorsal aspect of the distal phalanx also. This is the pictorial representation of the cutaneous supply of median nerve in the hand. You can able to see median nerve supply lateral half of the palm and lateral 3 end of digits of the palmar surface, then nail buds, then the skin over the lateral 3 end of finger of the dorsal aspect of the hand also. Here you can see it supplies the fingertip of, that is the fingertip of the thumb, index, middle finger. So these 3 fingers is commonly used to feel any texture or for any particular objects. Okay, so this is acting like a third eye. Okay, so when we want to feel something, we will use commonly these finger. So because of this, this nerve is known as the median nerve is known as the third eye of the hand. Moving to the clinical anatomy of median nerve, we'll start with the injury at the level of elbow. Even if the median nerve is injured above the level of elbow, the deformity will be same because it doesn't give any branches in the axilla or in the arm. So injury at the level of elbow is most common because of the supracondylar fracture of the humerus and tight application of tourniquet at the level of arm, or nerve entrapment is most commonly seen usually when it passes distal to the cubital fossa, that is in between the two heads of pronator teres or in the fibrous arch of the flexor digitorum superficialis when it goes deep to the flexor digitorum superficialis. In these location, nerve entrapment is common. In this case, patients will usually present with loss of pronation due to nerve supply to the pronator teres or pronator quadratus is getting lost. Then there will be weakness in the flexion at the level of wrist. There is no complete paralysis because this flexor carpi ulnaris and medial part of flexor discorum profundus is preserved because it is supplied by the ulnar nerve. So due to other muscle paralysis supplied by the median nerve, there will be weakness in the flexion of wrist. Then there is adduction deformity at the level of wrist because the abductors are paralyzed. The abductor includes flexor carpi radialis, okay, and also the lateral half of the flexor discorum profundus and the complete flexor discorum superficialis. These are the abductor of the wrist. So when these things are paralyzed because of the presence of adductor, these unopposed action leads to adduction deformity at the level of wrist. Then there is deformity known as Benedictine deformity of the hand. When the patient tried to flex and make the fist, the index and the middle finger will remain extended. Because of the long flexor tendon of these two finger is getting paralyzed. That includes the flexor discorum superficialis. It is injured for all the four finger. Apart from that, these two finger will be having the long flexor that includes the lateral half of the flexor discorum profundus, okay, which is preserved because it is supplied by the ulnar nerve. But here if we see the index finger and middle finger, the lateral half of the flexor discorum profundus supplied by the median nerve is paralyzed. So there is loss of flexion at the level of proximal and distal interphalangeal joints that leads to Benedictine attitude. And even in the thumb, the long flexor, that is the flexor pollicis longus, which is supplied by the deep branch of the median nerve, that is the anterior interosseous nerve, so that also damaged. Then one more deformity is known as the ape thumb deformity. This is happening due to nerve supply to the thenaris damage, so that leads to lateral rotation of the thumb and adduction because the adductor pollicis is supplied by the ulnar nerve. So unopposed action of this adductor pollicis results in ape thumb deformity in the median nerve injury. Then we all know the cutaneous supply of the median nerve. So that also lost as the injury is at the higher level. Then we'll see injury at the level of wrist joint. This is mainly due to deep cut wound, most probably the suicidal cut. So if the cut is in the superficial plane, it may not injure the median nerve because it is stopped by the flexor carpi radialis and other tendons. Okay, so if the cut is deeper, then it may lead to injury to the median nerve. So we all know the ape thumb deformity will occur because these recurrent branch arises in the level of hand. Then again the loss of cutaneous sensation in the hand due to the cutaneous nerve damage. Next we will see the injury at the level of mid forearm. Again this is also probably due to the suicidal cut or deep cut wound at the level of mid forearm. Here the clinical feature will be similar to the injury at the level of wrist. In addition to that, there will be one more feature known as pointing index finger. This is due to we have already seen the branch to the radial head of flexor discorum superficialis is at the level of mid forearm. Okay, so if the injury is proximal to that, then it will lead to loss of flexion in the index finger. Okay, so that leads to pointing index finger deformity. Then again the ape thumb deformity and the loss of sensation in the lateral half of the palm and the lateral 3.5 digit is same as the level as the wrist, injury to the distal wrist joint. Okay. Then apart from that, injury at the level of carpal tunnel, not the injury, mainly the compression here. Okay, so here the injury mean compression at the level of carpal tunnel. There is a separate video on the carpal tunnel syndrome including the test clinical features. So that I will give in the description. That's the anatomy of median nerve. Moving to the concept based MCQs. Question number 1. Relation of median nerve at the level of distal forearm or wrist. Medially radial artery. No. Actually, we have seen radially radial artery. Radially means laterally. Okay, so this is not the right answer. Laterally, the tendon of flexor carpi radialis. We have seen in the flexor carpi radialis, the medial one is the median nerve. So, when compared to the median nerve, this will be the lateral. So, this will be the right answer. Option C, both 1 and 2 are correct. No, none of the above. No, the answer is laterally tendon of flexor carpi radialis. Hope you remember this image. This is the median nerve. Just lateral to that, we are having the flexor carpi radialis. Still laterally, we are having the radial artery. All of the following are correct regarding the median nerve, except labrador's nerve. Yes, median nerve is the labrador's nerve as it supplies most of the muscles of the front of forearm. Injury at the wrist leads to pointing index finger. Is it correct? No. Injury at the mid forearm level leads to pointing index finger as it supplies to the this medial radial head of the flexor discorum superficialis. Okay, so this is not the correct one. Third eye of hand, we all know this, the median nerve supply the fingertips of lateral three finger, which is helpful for feeling any object like a stereognosis, so which is considered as a third eye of hand. And from its formation we know it includes all the branches, all the roots, that is from the C5 to T1. So all these are right except the second. Injury at the level of mid forearm leads to the pointing index finger, not at the level of wrist. Why median nerve is known as the eye of the hand? Okay, as it supplies the muscles of front of forearm? No. As it supply the intrinsic muscles of hand? No, it supply only two intrinsic muscles, that is the lateral two lumbricals. As it supply the cutaneous innervation of the lateral half of the palm? No, here also it, it's not because of the palm, it's because of the cutaneous innervation at the lateral three end of digits. Okay, mainly the fingertips. So this is the correct answer. Thank you for watching the video. Hope you understand the clinical anatomy of the median nerve in detail. So subscribe to our channel for more relevant contents. Thank you.